Hello, I'm Dr. David Kent. Thank you for coming to my weekly video podcast that I'm trying to do moving forward. I'm really excited this week. I have got a great uh, opportunity to meet with Dr. Mark George. Mark George is board certified in both psychiatry and neurology. He has pursued a research track his entire career. He's been continuously funded by the National Institute of Health since his fellowship started in the 1980s. He's published over 500 articles or chapters and has written or edited 6 books. He has received numerous international awards for his work. He is the original pioneer behind the early research and discovery of TMS as a clinical tool. His expertise includes areas of brain research such as neuroimaging, brain stimulation techniques, many of which he pioneered himself. He is the most well-known name in TMS. He works on the faculty of the Medical University of South Carolina in Charleston, and I found him to be extremely approachable and humble with all of his accomplishments. I first met him in 2017 in Barcelona, Spain, where I attended my very first TMS conference, which was an international brain stimulation conference, which he ran the conference and he started this conference as well. That's when I first got to meet him and talk with him. It's a great privilege to have him on my show today. I'm really excited. He's really the biggest name in TMS in the world right now. So for me to have him on the show is really great. So with no further ado, I'm going to introduce you to Dr. Mark George. Well, I've got Dr. Mark George on my program this week. I really appreciate it. We were kind of talking just a minute ago. I've already done an intro on Dr. George, so you kind of know about him. So we're just going to dive right in and respect his time a little bit. He's there in South Carolina, I'm assuming, at his house. So thank you, Dr. George, for participating today.
I'm here on beautiful Sullivan's Island, South Carolina. The ocean is about a stone's throw that way.
That's not fair. That's not fair.
It's about 65 degrees and sunny. It's about as good as it gets here. So anyway, I'm doing okay. Nice to talk with you.
I'm not feeling sorry for you whatsoever. So that's good. Well, I'm glad you're enjoying it. That's good. You deserve it. So let me ask you, a lot of these questions are fairly generic questions that I actually put out there on the internet at Reddit and also through my staff, and just kind of lay people questions about TMS, kind of understand it better, because I want people to understand TMS better and not have this weird idea about it. So the first kind of simple question is, how long did it take for TMS to go from a concept to clinical use? And I sort of know your time frames, but I know you kind of was discovered in 1985 or so.
Well, Tony Barker figured out how to make a TMS coil that could get into the brain in 1985, and it was first done then. But I actually first thought about using it for depression in 92. So I first saw it when I was at Queen Square in 89, 90. They were using a motor system. I had the idea that if we went prefrontally repeatedly, it might work. So I had the idea in 93, did the first studies at the NIH in 94 or 5. Wasn't until 2008 that we got FDA approval. So, 13 years of wandering in the wilderness.
What about in Europe, though? Because the US has, the FDA restrictions, but Europe has a little bit laxer rules.
No, there wasn't really much use there. People were almost warier in Europe than they were in the US. US actually was the one that led it towards clinical market. Some of the trials there had been done, but they really weren't large trials or convincing in ways to use it clinically. So it was 2008 in the US before we got FDA approval. And then it took a while to kind of get public opinion changing. And then the battle with insurance companies, which in some ways is still ongoing, was really hard. And so anyway, it took a while, but we're here now, and it's a great treatment.
Yeah, great. So another question I get a lot is, how does TMS work?
Well, we pass a magnetic field into the brain unimpeded through the skull, and we induce electrical current to flow in the cortex. So somehow it must have to do with tickling the cortex of the brain repeatedly. What's it doing after that? Well, my idea back then was that depression is an imbalance in the cortex, which kind of regulates our emotion, and then this limbic region kind of deeper down where all these emotions flow out of. And then in depression, you lose your ability to really think through flexibly and kind of control emotions. And so by stimulating this part of the brain repeatedly, we re-establish that connection and dominance. And that was the idea. And now we have all these very fascinating imaging tools where we can actually look at sophisticated concepts like dynamic functional connectivity. And sure enough, that is what's going on. So that's a fancy way of saying we're restoring kind of this network balance. I tend to think of it though as like going to the gym. You know, if we pulse this part of the brain, it's kind of like, you know, lifting a barbell. And over time, if you do that, your muscles are going to get bigger. Obviously, I need to do more of it. but I think of it like exercise, you know, in terms of exercising the circuit that is so important in health and is not really working in depression. And so, you know, that's the simple 10,000-foot view. If you get down into the molecular mechanisms, which are important, it gets a little bit complex, although that's being worked out in all these really wonderful animal studies. But the basic thing is, I think we're exercising that part of the brain and bringing it back online.
I agree. That's kind of my simple analogy I give to people when I talk to them. But also when I go to conferences, I hear about neuroplasticity, and that by exercising a particular circuit in the brain, that circuit seems to get maybe more connections, maybe more cells possibly, but possibly enlargement of the amygdala. So we see
studies have been done now that show that actually when you do 6 weeks of prefrontal TMS for depression, the brain does increase in size in selective regions underneath the coil and in the cingulate gyrus deep down in the brain. So we actually do grow the brain. Now, what are we doing by growing the brain? I don't think we're making new cells. It takes a while for new cells to be made and grow, and that wouldn't be a lot. So I do think we're actually increasing the amount of connections. So if a single cell, you know, after TMS, we've got a lot more connections between cells, and I think that's
maybe the dendritic connections are increasing, possibly.
And the animal studies are kind of
supporting
showing that that's likely what we're doing, and that's good. So the analogy of exercise and muscle growth, I think, is a reasonable one, and I think that's kind of what we're doing.
Okay, and plus with that durability that we see with TMS over other options, it sort of supports the idea that we're changing something in the brain.
Right. If I've gone to the gym a lot, even 6 months later, I'll still have a little bit of muscle memory, and I might be able to pick up a weight that I couldn't had I never gone to the gym.
Yeah.
So I can deal with whatever new wrinkle life throws at me, like a COVID pandemic.
Yeah. Like one of those things. Who would ever be in one of those? Right. Another question is, these are common questions, but I think it's good for you to speak to them, is in all your research, because you've been involved as a researcher for decades now with TMS, have you ever come across any long-term side effects with TMS?
It's a funny question. So we were very concerned at the beginning about this, because I've always said that anything that has the power to cure has the power to harm. And I think that's true. And so we were finding these curative effects, these therapeutic effects. So what harm could we do? Well, you know, you can ask that in large animals or human cohorts. And so far, long-term, we really haven't seen any deleterious problems in humans. There have been a lot of people around like myself, and I do TMS on my own brain, you know, in studies and everything off and on for years. And there are people like myself and John Rothwell and some other, the pioneers. We've been doing TMS forever. And when we get together, we joke that, well, it may cause baldness and a little bit of stubborn thinking, but
other than that, you're good, right?
Right. But you can do this in a scientific way in, you know, small animal studies. So a rat doesn't live 80 years, a rat lives 2 to 3 years. And so everything is compressed. And so you can do lots more TMS to a small animal, a rat or a mouse, than you would ever do in humans. And then look and see if and do a lot of them and see if cancer happens, if you have other changes. And those studies have been done, and we failed to find any long-term deleterious effects. So far, it looks quite good. But you know,
when you're first studying TMS in the very early days, what kind of safety protocols did you have to have when you started to go towards humans? Did you do animal studies first and then you work towards humans?
Well, yes and no. So I don't know if you know the story about Tony Barker, who was a physicist working in Sheffield, and he was trying to devise a capacitor that could hold a charge and discharge it rapidly enough to be able to create the magnetic field that would travel far enough to get into the spine. He was able to do that and show the spine could be stimulated. And he knew that he could get into the brain in terms of the distance, but he was afraid to, because back then we were thinking that the brain was a computer. And he knew that if he put this on a hard drive, he'd wipe the hard drive, and he didn't want to wipe someone's brain. So he was cautious and took it to Queen Square, which is where I ended up a couple of years later. And they were brave enough to do that. But everybody was very worried about what we were actually doing. So some of the early studies that we did was we compared TMS in the brain to actually just moving your thumb volitionally in terms of looking at blood flow. And those early studies showed that when we do TMS to wiggle your thumb, it produces the same amount of blood flow or oxygen use or metabolic use as volitional movement. And that was really reassuring, because it says, all right, all we're doing is just making the brain do what it does normally. It's not that we're doing something 1,000 times bigger. Nevertheless, people were quite concerned, and the FDA was right down the road. We were in Bethesda, they were out in Rockville. And so for the early studies, we had to do blood pressure and pulse and rigorous everything. But over time, the more and more we did, it seemed safe, no real deleterious effects, except for the occasional seizure. And then we were able to figure out the parameters to avoid to not have seizures. And so early on, there was quite a concern about safety, but over time, we've gotten much more comfortable with that.
Yeah, I know. I've been doing TMS for about 5 years now, and I just really haven't seen anything that's made me concerned. But I still comes up, and you've been around the block longer than I have in terms of treatment. We're about the same age though, because I trained in the 1980s like you did, so I'm not too far off your age, I don't think. One question I got on Reddit was, can it overexcite neurons? And we know that you can get a seizure, so I guess that could be an overexcitation of neurons.
Yes, absolutely. That is a known side effect. But the thing about it is we understand now exactly how that happens. And it's not, as you know, just one parameter, one intensity. It's a combination of the intensity and then the frequency and then the time on and the time off. And so we've worked that out in these nice tables. And as long as you stay away from some of the combinations of those things, seizures are very, very, very unlikely.
Yep. Okay. So this is another question from someone else. Do you remember a particular point in time where you realized that what you were working on was revolutionary and would forever change people's lives, or some people's lives, with the treatment? Did you ever get to a point in time, so this is pretty important?
Yeah, I don't know that I realized it. I think I was afraid of it. I remember after the first patient that we did at the NIH, a woman named Margaret Brinder, who's come out and give interviews, so I can use her name, where she had been in the hospital for several years, treatment-resistant bipolar 2, and she hadn't responded to medicines. And we did TMS on her and produced remission. And so it was like, oh my gosh, but you never know if that's just placebo, it's high tech or whatever. And so I had kind of that thought after her. And then we were able to run it into a double blind study. And I remember the day we unblinded that double blind study, and it produced this wonderful graph of declining Hamilton with active, and then the sham going the other way. And I was so excited. I remember I was flying.
So that was in the mid 90s, right? The mid 1990s.
Yeah, 94, 95. And I remember I was just so excited, and I saw a colleague on the plane. I went over and I drew the graph before we had laptops.
Yeah.
So I knew that it had something. And then I had the fear. I said, oh my gosh, this could be something. And I lived in fear of making a wrong decision that would make it so that it wouldn't become a treatment. And so I struggled with what's the right decision. I did not get a patent because I thought that might
discourage.
Well, people wouldn't believe me. They wouldn't cooperate with me trying to get it done. So I made that decision not to get a patent. And I think that was the right choice. Although without a patent, there was no industry. And so it took Neuronetics to get a patent about the coil before they could
And
create a
and
company.
Brainsway as well, right? Brainsway's got a
Right.
patent on
So
their
the
coil
patents were
system.
around the coils and not the use. And so
Yeah.
anyway, so I never really knew that it was going to be a revolutionary product. I had the idea that it might, and then the fear that I would not do my job of trying to get it out there. And I've just been pleased and pleased and pleased with how it's taken off. As you know, we're learning more and more about it. I don't know if you saw the recent publication by Harold Sackheim in Journal of Affective Disorders, where Neuronetics published their 5,000 patient outcome. So everybody that's been treated in America since FDA approval, and the results are unbelievably good, way more than 60% response, almost 70, 80% response,
That's what I'm seeing in my practice. That's what I'm
really high
seeing.
remission. And so those are much, much better numbers than we saw in the early double-blind clinical trials. And so, it's rare that you get a treatment that works better in the hands of regular psychiatrists than it does in these rarefied trials. But sure enough, it does. And I think that's because good psychiatrists like you often still keep people on meds, whereas in the early trials, we had to take them off. Plus, you're doing supportive therapy while they're in there, probably behavioral activation therapy. You're doing some cognitive therapy. And so you're using all the other tricks that we have to grow the TMS response. And so that's why I think those results are better, but they're really good and so much better. I mean, these are all people for whom medicines have really been tried and not really are not the only answer, not sufficient. Yeah.
Well, just kind of from my personal standpoint, I've been practicing since 1990 in private practice, so 30 plus years now. I've done ECT in the past, 7 years. I've trained at ECT at the University of Iowa, so I was an ECT center. I've done all the prescribing, all the hospital work. I've done everything in my career. And there's points in time when you kind of get burned out. You're doing the same thing over and over again. And TMS has kind of revolutionized my whole life. I feel grateful that I have it. I see better response with my patients than I did with medications. I see more grateful patients now. So it's just been transformative for myself. So for whatever it's worth, I appreciate that.
Oh, you're welcome.
So
Hey, it's just great to have a tool that works.
it has, yeah, exactly. After years and years, because we're in the business of trying to help people, right? That's our
Right,
business,
right,
trying to help
right.
people and nothing else. So a few more questions. I'm assuming you're part of ongoing studies still. Are you still doing some studies right now or involved with some?
Oh yeah, I'm blessed to still be in the game. And yeah, we're doing continuing with TMS. I didn't invest financially in TMS, no patent and no, I don't invest in any of the companies. And so I'm actually fine if we find something better than TMS. And so a lot of the studies not only are around improving TMS, but saying, hey, is there something else we can do? So I'm dabbling with other
Other
forms of
types of
TMS.
stimulation and things. Yeah, I know you have a pretty broad research brush that you work with because you
Yeah.
have neuroimaging and you have ECT and vagus nerve stimulation and TMS, and so, which I like because you're really looking at things objectively and not through the lens of us being sort of a conflict of interest. Another question is, do you have any thoughts on maintenance TMS? I get that a lot. I know that I've been to conferences and I think that everyone sort of thinks that maintenance is probably a good idea for a lot of patients, especially people that have a tendency to relapse.
Yeah. So here's what I find. I say there's a rule of thirds for acute TMS. So out of 100 people, 30 will have remission. Their symptoms are essentially temporarily gone. Another 30% will get response. Their symptoms are cut in half, and unfortunately, a third it won't help. But if you take the people who've gotten either a response or remission, they all then say, well, what's next, doc? I'm better. What do I do now? And what I say is go out, and then there's another rule of thirds. So about a third of people will never ever need TMS again. We've done something that has gotten them out of a depression, and they're with meds, talking therapy, they never needed again. Another third will likely need another course within 2 years. But if they come back, we do another course. It's a high rate of re-response in the 90%. So, they get a course every couple of years, not a big deal. There is another third where they go a couple of months and they'll relapse. And in those people, we treat them again, they re-respond, and then we start thinking about whether we need to do some form of maintenance TMS. And so I was trained with ECT, so we essentially kind of do something where we treat them well again, and then we start a taper where they get 3 treatments a week, 2 treatments a week, 1 treatment a week, and then we try to go every other week, every third week, every fourth week to see how far they can go before they relapse again. And then that's what they need, and we give that as
As our
a
maintenance. So you
maintenance treatment. And
kind
I
of
remember Gary Casey, a psychiatrist from Canada. They were able to do TMS a bit before the U.S. in Canada, and he started up a clinical practice outside of Toronto. And he turned to me and he said, "You know, Mark, the maintenance is gonna. I found that it fills up about a third of my chair time over time after a practice." About a third of the hours of doing TMS are going to be people who are coming back for maintenance. And we've seen that here in Charleston. I don't know what your experience is, but there are a group of people for whom that's what you need, and that's good. And there's no long-term problem with that. So, yeah.
Yeah, that rings true for me. I'd say that's just about exactly right. So I've got people I treated 3 years ago, and I treated a whole family of 4 members of the same family, and none of them have, and they're all off meds. None of them have needed retreatment. And then I've got people that come back fairly quickly, and then people that come back a year or two later, and then they respond again. For the people that come back fairly quickly, I quickly go to the discussion about maintenance and trying to see if we can keep them, in good shape and on track. Because what's it worth to you to not be depressed and to kind of be functional and in part of your life? Because when you're depressed, you kind of check out a little bit. So
One of the questions is, are those people going to need TMS for the rest of their lives? If they do, that's no big deal. The person on planet Earth, I think, who's gotten the most TMS ever is a woman here in Charleston who was a nursing student when we first treated her, and she got well, relapsed, got well, relapsed, and we ended up having to do maintenance treatment for her about once a month. And we did that for 4 or 5 years, and we do neurologic exam 10 years, TMS anymore. And I wonder about plasticity. And it's really interesting that she no longer needs maintenance, which I find just fascinating. So I have a very small sample, but at least that one woman, she actually went on to get her nurse practitioner's degree, and she leads a dance troupe. And oh my gosh, she's a healthier person than I am. So it was wonderful to watch her grab her life back.
I've seen that with patients get their life back. I had a nurse come to me when I first started doing TMS, and she was on disability for 4 years because of depression. She went back to work as a nurse, got off her disability, and she's been grateful ever since. So it's pretty amazing to see those types of stories.
So we don't know when maintenance, whether it's lifelong or just for a while, and then the brain eventually figures it out how to stay well. Yeah.
Yeah. Well, that's good. That's a good point. Another question I got was, what about combining, now that we have ketamine on the scene, combining ketamine and TMS? I've seen a few things to suggest that could be not an unreasonable thing to do sometimes.
I don't have any clinical experience in that area. I've seen ketamine and I've seen a lot of TMS. I mean, it makes some sense maybe to combine it, especially if somebody's in a terribly acute suicidal state, because ketamine, at least if you read the literature, works pretty quickly, whereas conventional TMS can take several weeks. And so you might be able to get out of the gate faster with the ketamine. At least the data that I've seen shows that ketamine is not really that good in terms of long-term durability, whereas the data with TMS is durable. So marrying those two might get you a quicker response from the ketamine and then a more durable response from the TMS. So it seems pretty reasonable, but I just don't have a lot of experience, and I haven't seen much published in that area.
Yeah, I could see where it could be useful because we're getting patients who failed a lot of other things, right? So they're a little more difficult population. So their tendency towards getting suicidal may be a little higher. They're more hopeless. So having the ability to add some ketamine in, maybe just to kind of band-aid them a little bit too, wouldn't be a terrible idea. Another question, we're almost at the end of our questions here, and I know I've seen some of these at the conference. Any predictive biological markers you see on the horizon? I know there's the heart rate thing, and anything you can mention about kind of predicting what might be a useful protocol for people?
From the very early studies with the 30-30-30, we always wanted to say, well, who's going to be a remitter, who's going to be a responder, and who should we just not bother with? So we've looked for predictors of response or non-response. And in all the studies, we've looked at everything: eye color, height, gender, age. The really big one that always comes out is the degree of treatment resistance. So how many medications and ECT have you failed before? How long has your episode been? If you've been depressed 30 years, it's probably harder than if you're only 4 or 5 years depressed. So it's really that degree of treatment resistance, and then comorbidities, especially anxiety comorbidity, is a negative response predictor. But other than that, nothing really
Jumps out.
really comes out. There's always this hope that, wow, we just need to know how to personalize it in terms of the location in the brain. You mentioned one where you look at changes in EEG. Lots of people are doing brain imaging where you look at what part of the cortex either correlates or doesn't correlate with deeper structures. And there's promising bits at a group level, but nothing that's translated out into kind of widespread clinical use that you could use with most patients. The big thing that everybody's excited about now is giving theta burst, these kind of rapid pulses, which seems to be potentially as efficient, as effective and quicker. So a lot of people are experimenting with theta burst stimulation. And then my former student, friend and colleague out at Stanford, Nolan Williams, has just published a paper in the American Journal where he takes patients, brings them into an outpatient clinic and gives them 10 treatments a day for 5 days. So a huge amount of treatment in a week, really more than normal 6 weeks of treatment, and gets really good results, pretty rapid, and then with at least a couple of months durability. So people are experimenting around with these kind of accelerated protocols. So those are really exciting things, trying to better find the location, maybe match the location to symptoms. There's some data out of Harvard where, interestingly, if you're the kind of depressed patient who overeats and oversleeps and has low energy and low interest, you may do better with stimulation over here than if you're somebody who's anxious and can't sleep and can't eat, where it may do better if you're back a little bit. Very provocative. They're testing that forward in a clinical trial right now. That would be wonderful if as a clinician, I could do an interview and figure out what spot to go. So it's kind of a psychiatrist's dream, but we'll have to see whether it really is true or not.
Yeah, when I first started doing TMS, I just did the left dorsolateral prefrontal cortex, kind of the standard around the world. And now there's other locations, other circuits that we can try. And I've had success with that. When the first location doesn't work, I migrate to another one, and then I migrate to another one. Sometimes I've gotten to the third location and gotten amazing results. So it's nice to have some new options for sure.
Yes, it always is, right? Yeah,
definitely.
I agree.
So a few others real quick. Things come up like any TMS for like eating disorders or ADD or dementia, some of those things. I know that there's a lot of off-label things that go on and people look at these.
They are off-label. So right now we have 3 on-label uses: treatment-resistant depression, OCD, and as of 2 weeks ago, smoking cessation. I'm not sure if you're aware of that one.
I'm aware because I work closely with Brainsway H4.
Yeah.
I got the first H7 helmet in the clinical use in the US because I needed it early.
So that one came through. So we have 3 on-label, and then a whole bunch of work, as you say. Anything that's in the brain in a circuit could potentially be treated with TMS. And so there's a host of data that are pouring in. And let's see, ones that you mentioned were ADHD.
Well, eating disorders, attention deficit disorder, dementia, like Alzheimer's type.
Well, ADHD, there's actually an FDA-approved trigeminal neuralgia stimulation, actually, where and they do that while kids sleep or young adults with ADHD sleep. I have no clinical experience with that, but it's interesting. That's FDA approved now.
Wow.
And then dementia, everybody wants it to work. So far, the studies have been not that helpful unless there's a depression and a dementia, which is not infrequent, actually. And I've had lots of patients who come with what's called a pseudo dementia. They have a
Mhm.
history of depression in their lives, and they may be getting slightly demented, and they get really bad. And people around them say, well, I don't know if this is dementia, or, it looks a lot like the old depression. We have a hammer, TMS, and a nail, depression, and we can hit a nail, depression, wherever it is. And so if there's a depression inside of dementia, I've seen lots of patients who get a lot better.
I've
They
done that
still
with a
may have a
patient
little
too.
bit dementia, but they're able to get their activities of daily living back up, stay at home longer. So if it's a depression within a dementia, it works quite well. But
I've had a patient
exactly
like that with a mild dementia with a significant depression. Depression got a lot better, and there was
right,
more functionality with the patient. They could do more, and the family
yeah.
could see a difference. So I
Yeah.
definitely think that's useful. So
Eating disorders, I don't know if there's studies, but nothing convincing or anything available clinically right now.
okay, good. And then one last question. You kind of already answered a little bit, but what are you excited about for the future of TMS, or what conditions do you foresee benefiting in the future from TMS? Anything that you comes to mind?
Well, I've always been convinced that it works for pain. We did some of the early pain studies and it works just as well. And we've got this opiate crisis where everybody's looking for non-opiate treatments for pain, and it works. It works in post-surgical applications. It works in chronic pain. It works in fibromyalgia. I've been amazed that no manufacturer has gone for FDA approval for its use in pain. So there
Hmm.
certainly is a great deal of data showing that it works. And in my clinical settings, somebody who's depressed and in pain, man, their
I,
pain gets
if
better.
you
Or
if you don't
if they
mind,
have,
if you don't
pardon?
mind, I might reach out to you through my email to kind of get a few of those protocols, because I wouldn't mind
Yeah.
trying them out.
Or if somebody has migraines and depression, I mean, it really works well for pain. And then now that we have smoking cessation FDA approval, all of the addictions are candidates. Why not? If it works for smoking, which is one of the hardest to treat, it should work for any and all chemical addictions and maybe some of the processed addictions, like gambling or other things. Yeah.
I totally agree. And even possibly weight loss. I've heard that the H4 helmet from Brainsway could potentially work for weight loss. And
Well, to the
they
degree that it's an addiction like where people tend to overeat in a compulsive way, for sure.
right,
Yeah.
right, if they do it that way. Well, that's all my questions today, Dr. George. I really appreciate your time, a little bit longer than maybe you'd planned for, but I
Yeah.
really respect you, and I have a lot of admiration for what you've done. You've changed a lot of people's lives through your research and through your studies, and kind of being a humble researcher, a scientist who's inquisitive. That's really what it boils down to.
Yeah, I'm a lucky guy, and I'm really lucky that this has worked. And there are people like you that are spreading the word. So you're very welcome. And thank you for doing all that you do.
Okay, I'll look for you at the next meeting, and I'll run up and shake your hand.
All righty. All right. Take
Thanks.
care.
Thanks, Dr. George.
All
Appreciate
right.
it.
Bye bye.
Bye.